Before we begin, please ensure that you have watched our previous video on hypoglycemia, as this is a follow-up video. In this video, I will be presenting 3 real-life clinical scenarios related to hypoglycemia. Let's go. Miss Judy is a 73-year-old lady with type 2 diabetes who is being treated in the hospital for a community-acquired pneumonia. She is on insulin glargine and a mild correction sliding scale. The nurse called you because she's concerned about Miss Judy's mental status. She informed you that the patient is confused. She was not like that earlier. What would you do next? Whenever we receive a call about a change in a patient's mental status, it's crucial that we take a quick action. We immediately ask for a blood sugar check and a complete set of vital signs. It's important to note that we perform a blood sugar check regardless whether the patient is diabetic or not. In fact, whenever we receive any call about a new symptom or sign, we always request a full set of vital signs. For more tips on how to respond to a nurse call, check out my previous video, How to Respond to a Nurse Call. The link is provided below. You arrived at Miss Judy's room. The nurse was performing the blood sugar check and vital signs. You found that she was staring at the wall, not answering questions, but fully awake. Finger sticks blood sugar came back at 35 and her vital signs were completely stable. What would you do next? Miss Judy's blood sugar is critically low. Anything below 40, as we explained, should be treated with IV dextrose solution in combination with rapid-acting carbohydrates if the patient can safely swallow. Miss Judy was staring at the wall and not following commands, so we immediately pushed 2 amps of 50% dextrose solution, and within 5 minutes she started talking to us. At that moment we felt she was safe to swallow, so we gave her 2 glasses of orange juice to drink. Miss Judy's blood sugar was checked roughly 10 minutes after the 2 amps of D50 were administered. Her repeat blood sugar was 75. What would you do next? At this point, Miss Judy's blood sugar is more than 70. A long-acting carbohydrate meal should be provided. So we ordered a regular meal and gave her some snacks while awaiting her meal. And we ordered a blood sugar check every 2 hours times 3. I asked the nurse to make sure the patient eats all her snacks and meal. Her insulin glargine and correction sliding scales were discontinued, of course. Miss Judy's next 3 blood sugar values were 90, 120, and 130. Would you start the patient back on her diabetes regimen? These blood sugar values are still below 180, so we did not start any of her insulin back, but we switched her blood sugar check to ACHS before meal and at bedtime. Next morning, Miss Judy's blood sugar was 230 on her morning labs. Before breakfast and before lunch, blood sugar values were 250 and 260 respectively. What would you do next? Blood sugar values are now persistently above 180, so we restarted Miss Judy's insulin glargine, but at a reduced dose by 50%, and we started a mild correction sliding scale. She was apparently having a poor oral intake secondary to her sickness, and her home insulin glargine was resumed at the same home dose. Let's move to the next case. A 25-year-old gentleman was found unresponsive. EMS was called and he was intubated on the scene. Blood sugar checked by EMS was too low to read on the finger sticks machine. 2 amps of D50, 50% dextrose solution pushed back to back. Repeat blood sugar en route to the hospital was 55. A 3rd amp of D50 given. The family informed EMS that an empty bottle of glipizide was found next to the patient, and they are not sure how many pills were in that bottle. In the emergency department, initial blood sugar was 70. What's next? This young patient, of course, going to be admitted to the ICU. He's intubated. He's likely ingested a large amount of glipizide, so a prolonged and profound hypoglycemia is anticipated. A continuous infusion of D10 or 10% dextrose solution was ordered at 100 cc an hour, and blood sugar check every hour. The next day, the patient remains intubated in the ICU. His blood sugar values were averaging between 70 and 100, and he was awake and following commands. What would you do next? The patient blood sugar values were still not high enough to wean the patients off dextrose solution, so we continued D10 solution at the same rate and continued blood sugar checks every hour. The patient was awake and was successfully weaned off the ventilator. The patient was placed on suicidal precautions, of course. after he was extubated. The patient passed a swallow evaluation done 2 hours after extubation. What would you do next? At this point, long-acting carbohydrates should be provided. So we started the patient on a regular diet and continued his blood sugar check at the same rate. Now you could also at this point space out his blood sugar checks to every 2 hours instead of every 1 hour if you want to. The patient's next 4 blood sugar values after eating were 140, 180, 165 and 125. What would you do next? Now the patient's blood sugar values are more stable, but remember, he's still on D10, the 10% dextrose solution, and he's eating regular meals. At this point, we decided to change his fluid from D10 to D5 and continue AccuChecks every 2 hours for the next 8 hours. Next morning, the patient is tolerating a regular diet. His most recent 4 blood sugar values were 140, 160, 135, and 110. What would you do next? The patient at this point, blood sugar values remain stable. At this point, we decided to take the patient completely off dextrose solutions, continue regular diet, and space out his AccuCheck or blood sugar checks to Q4 hours. Next day, the patient's most recent 4 blood sugar values were 132, 162, 145, and 160. What would you do next? At this point, his blood sugar values are stable, so we discontinued his blood sugar check, but also you can continue doing AccuChecks before meals and at bedtime, AC and HS. And don't forget that we need to refer him to psychiatry given that he had a suicidal attempt. Let's move to the final scenario here. Mr. Vidal, he's a 69-year-old gentleman with type 2 diabetes on insulin glargine 40 units at bedtime and metformin 500 mg orally twice daily. He was admitted for right total knee replacement. The admitting physician ordered a diabetic diet, then NPO after midnight for his procedures. He resumed the patient's insulin glargine and metformin at the same dose, at the same home dose. You are the night physician and the patient's nurse called you saying the patient is going to be NPO after midnight, and if you still want to give the patient his insulin glargine and metformin, how would you respond to that? When the patient is NPO, all non-insulin and rapid-acting insulins should be suspended and long-acting insulin should be resumed but reduced by 50%. So in this case, we suspended his metformin, reduced his insulin glargine from 40 to 20 units. So we informed the nurse to give 20 units of insulin glargine tonight, and we added a mild correction sliding scale. Mr. Vidal underwent his knee replacement surgery the next day. He's back in his room eating his lunch and his pre-lunch blood sugar was 180. What would you do next? So Mr. Vidal is eating now, but his oral intake may be unpredictable at this point, as we explained in our first video in this series, Home versus Hospital for Diabetics. It should be safe at this point to restart metformin and increase his insulin glargine, but not back to his home dose yet. So we restarted his metformin, increased his insulin glargine to 30 units, and added bedtime snacks to prevent early morning hypoglycemia. And we continued with a mild correction sliding scale. You will not be wrong if you increase his insulin glargine to less or more than 30 units, or if you kept it at 20. In the end, use your clinical judgment as long as you are adjusting the treatment according to blood sugar values. Remember, we mentioned this before, blood sugar control is a dynamic process requiring continuous monitoring and adjustments. If you enjoyed this video, give it a like, share it with your colleagues, and subscribe to our channel if you have not done so. The next video, we will start talking about insulin. See you then, and thanks for watching.